On behalf of USOBI, it is my pleasure to welcome you to today's online session provided by our industry partner HOLOGIC and on occasion of the USOBI 2020 Online in the Breast Cancer Awareness Month. I'm also happy to welcome the speaker of today's session and Mr. Bob Martins from HOLOGIC, who will be the moderator today. I would like to remind you that you are able to ask questions via the chat box. They will be answered at the end of the session, but you can already ask questions during the lecture and the moderator will address them afterwards. So now I'm handing over to the moderator and wish you a nice lecture.
Thank you very much. Good evening and welcome to the second webinar celebrating our Breast Cancer Awareness Month of October in collaboration with USOBI. Today we will be talking about breast ultrasound with shear wave elastography in clinical routine. Our speaker today is Dr. Foucauld Chamming from Centre de lutte contre les cancers, Bergony, Bordeaux in France. He is a consultant breast radiologist and head of the imaging department. He spent a year at McGill University in Toronto on a clinical research fellowship. He is a member of the board and a scientific committee on the scientific committee of the CIFEM, the French Breast Imaging Society, have experience as reviewer and have published multiple papers. Sorry. Today, Dr. Chamming will share his experience with shear wave breast ultrasound elastography. He was an early adopter of this technology with a first publication in 2013 and now uses shear wave elastography in clinical routine at the Anti-Cancer Center and also train others on the use. We hope you will enjoy the presentation and ask questions for the Q&A session which will follow the presentation. And now I will hand over the talk to Dr. Chamming.
So hello, so I will talk about breast ultrasound with shear wave elastography in clinical routine and try to show you how we can use this technique in daily practice. So after a short introduction and a few words on the basics of the techniques, I will show you the potential clinical applications of shear wave elastography. We'll see the limits of the technique, and I'll try to show you tips and tricks for optimization of the technique in your daily practice. So as you know, nowadays, breast lesions are characterized according to their morphological features as reported in the Barros lexicon. You can see here this breast lesion. This is a very suspicious mass with irregular shape and distinct margins. So of course it is very suspicious. It is a Barrett's 5 lesion, and of course it was an invasive carcinoma. But in some situations, things are more difficult. Look at this case here. This is a probably benign mass. There is an oval shape in well delineated margins. So is it a complicated cyst? Is it a Barrett 3 lesion? So we thought it could be a cyst, so we decided to do a fine needle aspiration to empty it. But when we did this fine needle aspiration, we realized that this lesion was actually stiff, so it was much more suspicious, and we decided to do core needle biopsy, and this biopsy found an invasive ductal carcinoma grade 3. So this case shows us that in some situations, morphological criteria are not sufficient to characterize well breast lesions. So we need an additional parameter. And with this case, we understand that stiffness could be this very interesting parameter. Actually, stiffness is known as an interesting parameter for centuries. It is used in daily practice in clinical examination, and Hippocrates already observed that stiff breast lesions were much more suspicious than soft lesions. And nowadays, with shear wave elastography, we are able to evaluate non-invasively stiffness of non-palpable breast lesions. So the technique of shear wave elastography. So in this technique, this is a probe that generates an acoustic wave called the acoustic radiation force, and this wave is focused in different point of the tissue, and this so it will shear the tissue, and the sheared tissue will generate shear waves, which direction are perpendicular to the direction of the acoustic radiation force. And the speed of the shear waves is directly related to tissue stiffness with the formula E equals 3 rho CS square, where E is stiffness, elasticity, also called Young modulus, rho density of the environment, and CS speed of the shear waves. So if you're able to measure the displacement of this wave, you're able to measure quantitatively stiffness of the tissue. So with this technique, we are able to evaluate stiffness of the tissue within the breast. And typically with this technique, stiff tissue appear as red and heterogeneous lesions. It's often in very stiff lesion, stiffness often displayed as a peripheral ring called stiff ring sign. On the contrary, soft lesion typically demonstrate homogeneous blue color map. So numerous publications have initially evaluated the performance of shear wave elastography, but they initially compared the value of shear wave elastography alone versus beam-bot ultrasound. And doing this, they showed that shear wave elastography had good performance with good sensitivity and specificity, but this performance were not significantly better than those of beam-bot ultrasound. Then the authors realized that actually the interest and value of shear wave elastography was depending on the aspect, the pattern of the lesion on beam ultrasound. When the lesion is typically typical, like in this case of this typically benign lesion here, or of this typically malignant lesion here, the stiffness information has really little interest because it doesn't change anything in your management. You will biopsy this lesion anyway, and you will be sure that this lesion is benign anyway. On the contrary, when you have indeterminate lesions, like in those two non-mass-like lesions, it's much more difficult to make difference between benign and malignant lesions. So which one is a cancer, which one is benign? In these cases, you really need this additional stiffness information to be confident. So here, yeah, with shear wave elastography, you're much more confident to say that this lesion is probably benign and that this lesion is highly suspicious. So shear wave elastography should really be used in addition to beam ultrasound for indeterminate lesions. So subsequent studies have evaluated this, the value of shear wave elastography in addition to beam ultrasound for indeterminate lesions. This is a case of the BE1 study, a prospective multi-center international study that evaluated shear wave elastography on more than 900 breast masses. And they evaluated a strategy in which BIRAT 3 lesions that were stiff were downgraded to BIRAT 4A, and BIRAT 4A lesion that was soft were, BIRAT 3 lesion that were stiff were upgraded to BIRAT 4A, and BIRAT 4A lesion that was soft were downgraded to BIRAT 3. And doing this, they showed that they had no significant difference in sensitivity, but they observed a significant increase of specificity of 17%. So all other studies also showed this, that for characterization of indeterminate lesions, shear wave elastography could really increase specificity. But in our daily practice, in what situations can shear wave elastography would be really helpful? So I think there are 4 clinical situations for which shear wave elastography could be really useful. First, for characterization of indeterminate breast masses. It could be also helpful for characterization of subtle images that are, by definition, often difficult to characterize. There are some situations in which elastography also could be helpful for characterization of microcalcifications when they are visible under ultrasound. And it also could be very useful in the signal-like ultrasound context, in particular after breast MRI. So we'll illustrate all these four situations. So first, indeterminate breast masses. You have here two cases of two lesions in two different patients. On the left here, you have a palpable mass of the left breast in a 28-year-old young patient. And here, a non-palpable mass of the right breast in a 45-year-old patient. So on the basis of morphological criteria, it could be difficult to say if these lesions are cancer or suspicious or not. And so it is obvious for you to say which one is a cancer and which one is benign on the basis of morphological criteria. So let's see now with shear wave elastography. You can see that this lesion here is very stiff and very heterogeneous, so it's very, very suspicious. And this one is perfectly blue, so perfectly soft, and of course it's much more probably benign. So, and actually, this one was an invasive ductal carcinoma and grade 3, and this one was a benign lesion. So it really increased our confidence for lesion characterizations. Another situation in which shear wave elastography could be useful is for the characterization of subtle images. And first of all, it could be useful for non-mass-like lesions. Non-mass-like lesions are all breast ultrasound lesions that do not fulfill the criteria of a mass. So usually they're ill-defined, they have ill-defined margins. They are heterogeneous, and so they are difficult to characterize. It's difficult to say if they are Barrett 3 or Barrett 4 lesions. So there have been two recent main publications showing the interest of shear wave elastography for these lesions. And this publication showed that elastography could increase specificity of breast ultrasound from 24 to 91%, and therefore could reduce the number of benign biopsy of 79%. So let's see now a case, two cases. Here are two non-mass lesions in two different patients. On the left here, 40-year-old patient. On the right, 60-year-old patient. Once again, it's very difficult to well characterize this lesion on the basis of their morphological criteria. So what do you think? Which one is cancer? Do you think this one is cancer? Do you think this one is a cancer? Maybe difficult. So let's see with shear wave elastography. You can see here this lesion was soft, perfectly soft, and this lesion was stiff and very suspicious. And actually, this one was fibroadenoma and was benign, and this one was an invasive lobular carcinoma. Other type of subtle images are small lesions. Small lesions, by definition, are often difficult to characterize. You can understand that it's much more difficult to describe shape and margins in lesions measuring 5 millimeters than lesions measuring 2 centimeters. So look at this case here, 60-year-old patient. She had an ultrasound after a normal mammogram, and we found this small mass, very difficult to characterize, difficult to evaluate shape and margins. So let's see what shear wave elastography tells us. We just move the probe over the lesion. Yeah, you see the mass, and there is a clear area of stiffness of the lesion. So the lesion is really stiff. This is much more suspicious, and there is a clear indication of breast biopsy. So we did the biopsy, and actually it was an invasive carcinoma. Another case here, another small mass. You can see it seems to be an irregular mass in a 41-year-old patient, and this patient had BRCA2 mutation. So of course it was kind of suspicious, but it's still small and difficult to evaluate. So let's see what are the shear wave elastography findings. So you see no stiffness of the lesion. Yeah, it's perfectly blue. It's really soft. So it's much less suspicious, and of course the patient had a mutation, so we did a biopsy anyway. But when the biopsy found a sclerosing adenosis, we considered this result as concordant with imaging features. So this is another interest of shear wave elastography. Can really help for assessment of the concordance between pathological results and imaging findings. Shear wave elastography can also help in some situations for microclassification. As you know, mammography is the gold standard for evaluation of microclassifications. But mammography has a low specificity and then yield a large amount of benign biopsies. It has been reported that up to 30 to 40% of microcalcification can be seen on ultrasound. And when they are seen on ultrasound, we have shown recently that a shear wave elastography could help characterize these microcalcifications. We have shown in this study that actually malignant calcification are stiffer than benign calcification. This difference was very significant. You can see here 2 cases, benign calcification that are completely soft, and here malignant calcifications that are stiff, very stiff. So when looking at the results, we found that when we found microcalcification on the ultrasound, and we measured and we evaluated shear wave elastography, we showed that when we had softness, when the image was perfectly soft, in most cases was benign microcalcification, but also some malignant calcification could be soft. So that's why sensitivity is not perfect, and softness on shear wave elastography does not eliminate malignancy when faced to microcalcification. On the contrary, when we observe eye stiffness over the calcifications, you have a very good specificity. So eye stiffness was associated almost always with malignant lesions. So that's why we had in this study a very high specificity of 100%. So we showed that really shear wave elastography could help differentiate benign and malignant calcification with a good specificity. So how can we use this in daily practice? You look at this case of an 87-year-old patient. This patient had a personal history of left breast cancer, and she had developing microcalcification on follow-up mammogram. This calcification was suspicious, so there was an indication for biopsy. But patient was old and not in very good shape, so it was difficult to set her in a prone position for stereotactic guided biopsy. So we looked for the calcification under ultrasound. So look at the ultrasound, and we found this hypoechoic with hyperechoic dots. So possibly the calcification are here. So look now at shear wave elastography to see what it tells us. You can see that over this hypoechoic area, there is a clear area of stiffness. So it is very stiff, and that tells us 2 things. First, the calcifications are here, so we can do the biopsy targeting this area here. And secondly, because it is very specific, this calcification are very, very suspicious. So we did the biopsy under ultrasound guidance, and we using a 10-gauge vacuum-assisted breast biopsy, we retrieved some calcifications and found a ductal carcinoma in situ. So thanks to elastography, we really could do the ultrasound-guided biopsy with high confidence, and it could avoid the stereotactic biopsy in this old and relatively bad shape patient. Another clinical situation in which shear wave elastography could be really useful is for single-look ultrasound, and especially after a breast MRI. It has been reported by Plesha in Radiology in 2014 that shear wave elastography could improve detection and characterization of breast lesion on single-look ultrasound after MRI. They also showed that elastography could improve targeting of US-guided biopsies of these lesions. Look at this case here. It's a 45-year-old patient with invasive lobular carcinoma of the left breast, and you can see this is the invasive lobular carcinoma here. And on pre-treatment MRI, we found an additional suspicious mass, a very small mass here. So we did a single-look ultrasound and look at the beam ultrasound. It was very subtle. Maybe we had a doubt on this area here or here. Maybe there is something suspicious. Maybe it could be isolation, but it's not. It's very doubtful. It's difficult to be confident to do the biopsy targeting this image. So we did shear wave elastography on this area here. Look at the results. Just move over the image and you can see very easily that there is a clear area of stiffness here. So yes, it confirms that the lesion is here and that it is very, very suspicious. So we did the biopsy targeting this area of stiffness and found an ipsilateral additional invasive ductal carcinoma. Another case here, 53-year-old patient. She had a personal history of left mastectomy and she was a BRCA1 carrier, so that's why she had MRI follow-up. And on the follow-up MRI, we found this small developing mass. So we did a second-line ultrasound, and on ultrasound we found this small round mass. So it seems to be a probably benign mass. It is round with well-delineated margins, but it is known that on second-line ultrasound the lesions are more often probably benign, even if they are cancer, than in usual BMO ultrasound. So it's difficult to evaluate very small mass. So let's look at the shear wave elastography. You can see here that when we hover the lesion, there is an area of stiffness. So yeah, even if morphological criteria are not so suspicious, using shear wave elastography, it is clear that the lesion is suspicious and that we have to do a biopsy, and that the lesion is probably in correlation with MRI findings. We did a biopsy. It was an invasive carcinoma in correlation with the MRI image. So we've seen that the shear wave elastography could have very interesting potential application in clinical practice, but as any other imaging technique, elastography also has limits. There are false positive and false negative results. And moreover, just exactly as BMO ultrasound, results are variable according to first conditions of acquisition and second experience of the operator. So there are false negative results. Look at these two cases here. Here, a palpable mass in an old woman, and not so suspicious on beam ultrasound, but there is a hypoechoic area. And on shear wave elastography, it's very soft. We did a biopsy anyway in this context, and it was a mucinous carcinoma. Look at this other case here, calcification initially found on mammogram, and this calcification were visible on ultrasound, and they were soft on shear wave elastography. But as I told you previously, softness with calcification does not eliminate malignancy. So we did a vacuum-assisted biopsy of this calcification anyway. It was ductal carcinoma in situ. So there are false negative results. Some cancers are soft, and soft does not always mean benign. There are also false positive results. You can see here is a small mass, maybe irregular shape, not easy to evaluate, maybe suspicious, very stiff on shear wave elastography, so very suspicious. And anyway, it was only a fibroadenoma. And look at this hypoechoic area here, seems to be once again very suspicious. It is very stiff on the shear wave elastography, and anyway, it was a benign lesion and dense collagenous stroma. So some benign lesions are stiff, and stiff does not always mean malignant. See, another limit is that results of shear wave elastography depend on conditions of acquisition. It's look at this race car here. You can understand that it's not the same to drive this car on a dry paved road or on ice. This is exactly the same, like for beam ultrasound for shear wave elastography. The results of shear wave elastography will depend on type of lesion. Is it a mass? Is it non-mass-like lesions? It will depend on the location of the breast. Is it deep lesion, a superficial lesion? Is a lesion located behind the nipple? It will depend on the type of breast. It won't be the same results in big fatty breast or in small breast with high amount of fibroglandular breast tissue. And it also depends on level of compression applied on the breast. So finally, the overall findings of shear wave elastography depend on the experience of the operator. So there is an impact of compression applied on the breast on shear wave elastography results. Look at these two cases. There is here a benign lesion and a malignant lesion on beam ultrasound. And if we apply absolutely no compression, which means we used a layer of gel between the probe and the breast. So with no compression, both lesions seems to be soft. So we observed that actually total absence of compression is not optimal for a shear wave elastography. So anyway, when you do a beam ultrasound, you in almost all cases apply a manual pressure on the breast just to have a good beam body image. When we applied a slight compression, then we obtained this stiffness of the malignant lesion while benign lesion stays blue and stays soft. When we increased a little bit the amount of compression applied on breast, so with a moderate compression, we can see that stiffness of the malignant lesion increased, but we also get yellow and maybe a red images over the benign lesion, so it becomes to appear stiff. And when you apply a very strong compression, then even the benign lesion appears very stiff, and it's much more difficult to make difference between the benign and the malignant lesions. So we've shown that absence of compression is really suboptimal for characterization of breast lesion with shear wave elastography. So you have to apply a slight compression of the breast, but this compression should be not too strong. It's also important to note that the impact of compression on the breast will vary according to the type of breast. Look at here, compression on a very small and dense breast. When we apply a pressure, you can see that we get a real increase of stiffness, as a normal breast tissue seems to be stiff. So you understand that in this kind of breast, you would easily get false positive results. Here, a big fatty breast, and we will once again apply compression, and you can see no change. Breast stays blue and seems to stay perfectly soft. So the risk of false positive results is much lower in fatty breasts than in dense breasts. So the technique is really variable according to the experience of the operator, exactly like for beam ultrasound. Look at this case here, suspicious mass on beam ultrasound. And here are the shear wave elastography findings in an operator with very little experience in shear wave elastography, and the same image was acquired with an operator with more experience in shear wave elastography, and you can see that the results are clearly different. So there is a learning curve, and this is very important to learn the technique. So we see that there are limits, so we'll try to see some tips and tricks to really optimize the use of the technique in daily practice. So first of all, morphology and morphological criteria should be used first before interpretation of shear wave elastography. Look at this case here. This patient has had a personal history of ipsilateral cancer, and she had a developing mass on the follow-up mammogram. And you can see this mass is very suspicious, irregular shape, and distinct margin. So clearly it's a Barrett's 5 mass. And you can see here on beam ultrasound the image, very suspicious. So even if you got something like that and seems to be soft on shear wave elastography, because the image is very suspicious, please do a biopsy. So morphology first. Then qualitative or quantitative analysis. I personally recommend, and it is recommended to use qualitative analysis in clinical practice. Quantitative analysis is sometimes difficult because the optimal threshold we should use is unclear. It's unclear because it's variable in literature. The threshold reported in the different publication are really variable, and also the threshold will depend on the compression applied on the breast. There are also several parameters, and it's not perfectly clear which one we should use. Maximum stiffness, mean stiffness, or stiffness ratio between the lesion and the surrounding tissue, it's unclear. It's also unclear where the region of interest should be positioned, over the anterior lesion or over the stiffest part of the lesion. On the contrary, quantitative analysis allows evaluation of the overall stiffness of the lesion, It allows evaluation of the color distribution and contrast between the lesion and the surrounding normal breast tissue. It also allows dynamic analysis, which is of great interest, in particular to manage the amount of compression we should apply on the breast for optimal results. So in practice, qualitative analysis is really recommended. Another thing is, just like in beam ultrasound, is to evaluate reliability of the technique before interpretation. So look at these two cases here. On the left, you got a very small mass. This mass is located deep in the breast. This is a small breast with a large amount of fibroglandular breast tissue. So there is a higher risk of false positive results, and I won't be very confident in this area of stiffness here. So there is really poor reliability. But on this case here, you see this is a big fatty breast, so I know there is a very lower risk of false positive results. So lesion is more superficial, so this is a much more reliable examination, and I will be much more confident to say that the lesion here is actually stiff. Another tip is to learn how to manage compressions. So the idea is to look for contrast between the lesion and the normal surrounding tissue. And to do that, we can calibrate the optimal level of compression on normal breast. Look at this case here. A patient with a very subtle suspicious image in the middle of the image here. The patient had neoadjuvant chemotherapy, so we looked for something very subtle. So first we try to calibrate the amount of pressure applied on the breast here on normal breast, and you can see that probably the amount of pressure is too high because we have these yellow waves here, so too much pressure. Then the amount of pressure here also on normal breast is much better because the image is perfectly blue, the quality of the image seems to be okay. And then you can just move the probe of the lesion with the same level of compression and see if there is any stiffness, because if you don't change the pressure applied on the breast, if you get stiffness, the stiffness is related to the lesion and not to your condition of acquisition. So just move over the lesion, and you can see that there is clear stiffness here. So this is much more suspicious, and actually there was an invasive cancer here. Another tip is using the jumping sign. The jumping sign is helps you evaluate whether stiffness is really due to the lesion and not induced by too strong compression applied of the breast. So look here. The lesion is here. There is an area of stiffness, so it is due to a too much amount of pressure. And if you just move the image, you can see that stiffness will jump over the lesion. You can do that on the other direction. You can see that stiffness once again will jump over the lesion. So it really confirms that stiffness is generated by the lesion itself and not by a too high amount of compression. So as a conclusion, we can say that shear wave elastography increases performance of breast sonographers in clinical practice, in particular for the characterization of indeterminate breast masses, for subtle lesions. Sometimes it can help for microcalcifications when they are visible on ultrasound. It also can really increase performance and could help target biopsies in second ultrasound after MRI. Like any other imaging technique, shear wave elastography has limits. There are false negative and false positive results, and the results depend on the conditions of acquisition and expertise of the operator. So there is a learning curve, and that's why teaching is crucial. So I think it's very important to take time to really learn the technique and to have a technique that is really optimal for characterization of breast lesion in your daily practice. Thank you for your attention.
Thank you very much. And now we will take the question which has come in during the presentation. So I have a first general question. Do you systematically use shear wave elastography for all your diagnostic cases, or are there special selection you do for when you apply that?
Thank you for this question. Actually, as I showed in this presentation, shear wave elastography can really be useful only for indeterminate lesions. When the lesions are typical, usually I don't have a look on shear wave elastography results. If you are a typical cyst or a typically suspicious lesion, I just don't turn elastography on. It can be useful to have a look when you start with a technique, just to learn the technique and see how it will be with typically suspicious lesions or with typically benign lesions, but not when you use the technique. It's not. Yeah, you can just use it for indeterminate lesions.
Thank you. I have a question regarding biopsy here. Can we cancel biopsy based on elastography?
I'm
Maybe
not sure.
The question is more like, can it help determining whether you, I will reformulate that question. I was just reading it off. But I think the question is, will elastography help you to determine whether you biopsy a lesion or not? Will it influence your decision?
Yeah, of course, it will change my decision, because it will really change the characterization of the lesions. So some lesions that seems to be probably benign, that I would not have biopsied initially, and if they are stiff, then I will do a biopsy, and sometimes I will find a cancer that on morphological criteria seem to be probably benign. And on the contrary, sometimes when I have a intermediate lesion and it is perfectly soft, sometimes I can make a decision to just follow the lesion and not do a biopsy. So clearly, yeah, it will clearly change my management of indeterminate lesions.
Okay, I think that also answers the question. Somebody was sending a precision here. In the case you have a BIRADS 4 in B mode and a BIRADS 3 in shear wave elastography, would you biopsy it?
If I got a 4A, like, you know, like an oval mass with well delineated margins in young patients, but the lesion had just increased a little bit, so it would be a BIRADS 4A, and in theory you should do a biopsy on the basis of the morphological criteria. But if the lesion is perfectly blue, it is really possible to downgrade the lesion to BIRADS 3 and just not do a biopsy. So yeah, if a BIRADS 4A that is soft, I want to do a biopsy, and a BIRADS 3 that is stiff will be a BIRADS 4A, and then I will do a biopsy.
Thank you. As a question here, what kind of ultrasound machine do you use in everyday practice? These shear wave images are great.
Yeah, they are very different. As I showed in the beginning of the presentation, there are different techniques: strain elastography and shear wave elastography. So this image are shear wave elastography, and this is here the device from the supersonic imaging I use. And they are the more advanced device for shear wave elastography, because they were first on that technique.
I have another question here. Is shear wave elastography useful for invasive lobular carcinoma detection and for size measurement of those lesions?
It is also useful for invasive lobular carcinoma as for any other carcinoma. So yes, invasive lobular carcinoma are stiff, so it could be really useful. But I don't really use elastography for lesion measurement, because sometimes it will, you know, your measurement will be bigger than the real lesion. So I still do my measurements on the B mode image.
Another one here who said thank you for a good presentation and ask, what about lymph nodes?
There are publications on the interest of shear wave elastography on lymph nodes, but I don't really use it I don't use it in daily practice, because I'm not sure it really change my decision. no, I don't use it in daily practice. It's very difficult to use. I'm not sure it will be useful for this application.
Okay, thank you. Another question, more technically here, what is the negative predictive value of shear wave elastography? I don't know if you can say anything about that.
I can't give a value here because it will really depend on the criteria, on morphological criteria on beam ultrasound. You know, there are false negative results, but they are not so frequent. Probably, I would say like 10% of or 5% of cancer could be soft, like in situ carcinoma or mucinous carcinoma or papillary carcinoma. But it will really depend on the morphological criteria on beam ultrasound. So I don't have a really value to give here.
A question here regarding your experience with strain elastography.
I've used strain elastography a little, but I'm not very experienced in using that technique. The techniques are different on the technical basis, and I think the experience is also different because shear wave elastography is really, you know, dynamic, and I think this is what is really useful in practice. But no, I don't have much experience with strain elastography.
A more technical question about the frequency of the probe that you're using.
The frequency of the probe for the beam mode image on beam mode ultrasound or for shear wave elastography?
It doesn't specify, so maybe talk about both.
The probe for beam mode ultrasound we use is 4 to 18 megahertz for beam mode ultrasound. So I hope this answer is okay.
Yeah. Do you use any specific cutoff for stiffness when you in quantification of elastography?
Not really, because as I said, I personally use only qualitative analysis, so only on the pattern of the image and not on the value I would measure, because I personally don't know what is the optimal threshold. When you look at the publications in literature, you will see that the recommended threshold are very variable, from like 30 kilopascal to 80 kilopascal, and it's very difficult to know which one to choose. And moreover, your threshold will, the value you will measure will vary according to the pressure you apply on the breast, which is not measurable. And you have to apply a slight compression, because if you apply no compression to have a really objective measurement, then the quality of the overall image is usually not optimal. So yes, use more a qualitative analysis. I think it's much more performant.
So in the cases where you apply shear wave elastography now with experience, what is your impression about the increased diagnostic confidence? I know that's difficult to quantify, but could you say it's 60% of the cases, 20% of the cases, 80, 90% of the cases where you as a person feel still with your experience today that it increased your diagnostic confidence?
It's very difficult to say, and I think it will vary according in what center you work, because I work in a tertiary center, so I'll see many suspicious and very subtle lesions. But I would say maybe, I think more than half cases, more than 50%. I think it really change because it allows you to decrease your you know, the size of the lesion you want to evaluate, to assess, and you can still look for 2 or 3 millimeters lesions and still be specific, because shear wave elastography really increases specificity, and so you won't do biopsy for benign lesion even for very small lesions. So it will change I think your overall performance in your daily practice.
Thank you. I think we are up against time here, so we will end the session. I will say thank you for everybody for spending the evening and listening, and we will make this recording available through the USOBI website also for later. Thank you very much, Dr. Foucauld Chamming.
You're welcome. Thank you.